Hello and welcome back to session 2 of the 3rd annual Completed Life Fall Conference. Earlier today in session 1, you heard a rigorous discussion about the ethical, legal, and medical implications of removing a state's residency requirement for patients who seek assistance in dying, vis-à-vis Gideons v. Brown 2022, the first in the nation to successfully challenge a state's residency requirement. In session 2, our panelists will discuss at great length how the cultural, medical, and legal norms struggle to accept positive connotations about a chosen death, vis-a-vis the hashtag death positivity movement. Washington v. Glucksberg et al., 1997, declined to find that a physician's assistance with active lethal means to cause death was constitutionally protected. The argument made by the petitioner advanced the physician's right to assist with a patient's chosen death, with the implication of reducing and relieving a patient's suffering. In comparison, Canada's progressive version of assistance with dying succeeded in the High Court, Carter v. Canada 2015, including a chosen death that is physician-administered. Critics of death with dignity legislation assert that expanded eligibility criteria will promote earlier deaths and negatively impact persons with disabilities, among other concerns. And yet, substantial data from both Canada and the United States demonstrate that the safeguards work. Beyond expanding end-of-life choice to include medical aid in dying, recent years have seen advocacy efforts in both Canada and the US to open access to therapeutic use of psilocybin with patients with advanced illness. For this session, I have the honor of welcoming Kathryn Tucker and Dr. Sandy Buchman to the Completed Life stage, moderated by our esteemed Thaddeus M. Pope. Kathryn Tucker is Director of Advocacy at the National Psychedelics Association, a founding board member of the Psychedelic Bar Association, and a founding member of the Initiative on Psychedelics of the Global Wellness Institute. Tucker served 2 decades as Director of Advocacy and Legal Affairs for Compassion and Choices, working to improve care and expand choice at the end of life. Tucker has served as lead counsel, representing patients and physicians in 2 landmark federal cases decided before the United States Supreme Court, Washington v. Glucksberg and Vaco v. Quill, asserting that mentally competent, terminally ill patients have a constitutional right to choose aid in dying. She has litigated similar state constitutional claims, including Baxter v. Montana. Tucker also played a key role in successfully defending the Oregon Death with Dignity Act from attack by the United States Department of Justice. Dr. Sandy Buchman was a clinician at a comprehensive family medicine practice in Mississauga, Ontario, for more than 2 decades before he decided to focus on palliative care. He worked full-time in home-based palliative care at the Temi Later Center for Palliative Care in Toronto for 15 years. He then took on work with the Palliative Education and Care of the Homeless, acronym PEACH. The service worked through the Inner City Health Associates. Dr. Buchman is now the Freeman Family Chair in Palliative Care at North York General Hospital in Toronto, Canada. He has been consistently involved with the Ontario College of Family Physicians since completing his residency. He has also been an active leader in national associations since then, both with the CFP and the Canadian Medical Association. And last but not least, our moderator for this session is Thaddeus M. Pope, a renowned health law professor and bioethicist, a foremost expert on medical law and clinical ethics. Professor Pope maintains a special focus on patient rights, healthcare decision-making, and end-of-life options. Pope is a law professor at Mitchell Hamlin School of Law in St. Paul, Minnesota, and while he serves in a range of consulting capacities, Pope has been particularly influential through his extensive high-impact scholarship. Ranked among the top 20 most cited health law scholars in the United States, Professor Pope has over 250 publications in leading medical journals, bioethics journals, and law reviews. He co-authors the definitive treatise, The Right to Die, The Law of End-of-Life Decision-Making, and he runs the Medical Futility blog with over 5 million page views and of course is an esteemed founding member of the Completed Life Initiative Steering Committee. Whether you are new to our Completed Life community or are a returning attendee, these sessions are invaluable learning tools meant to empower you to have an informed conversation for yourself and with your loved ones about the completed life. Keep thinking about questions that pop into your mind during the session, and feel free to input them into the Q&A box located on the lower right-hand corner of your screen. If you'd like assistance with closed captioning, take a look at your lower left-hand corner of your WebEx screen to initiate captioning for the spoken words of today's event. And of course, the recording will be published after the conference concludes. Without further ado, let's begin.
So thanks for the introduction, Sarah. So I'm Thaddeus Pope. I'm as you heard, a law professor, bioethicist, frequent author, consultant on end-of-life issues. So this afternoon, we're not going to have formal pre-prepared presentations as with the morning session. We're going to have a moderated discussion with these two very foremost speakers. We'll do that from 1 to 2 Eastern, and then we'll turn to take participant questions, your questions, from 2 to 2:30 Eastern. So be sure to be thinking of those, formulating those, and typing them into the Q&A box. So we heard, let me just recap this. So we heard Sarah say that Sandy Buchman is a palliative care physician in Toronto. He's also a MAID assessor, MAID provider, and also, apart from all his clinical roles, has had a lot of current and past leadership roles in healthcare, including president of the Canadian Medical Association. And Kathryn is a top-tier advocate for end-of-life liberty going back 30 years or more, but for the past few years has focused a lot on expanding access to psychedelic therapy. So I just want to start just by asking, you heard me give a 10-second thing and Sarah gave a little bit of something, but maybe we should start by just, if you guys want to describe a little bit more fully your background. Of course, we're going to get into psychedelics and we're going to get into MAID, so you don't need to dive deep on that. But just if there's something else, you want to flesh out in terms of your background, because you guys both wear so many hats, so maybe just describe a few of those hats and the things that you do while you're wearing those hats. Sandy?
Sure, I can go ahead. Thanks very much, Thaddeus, for the kind introduction. Yeah, just a little bit more on the background. I'm a palliative care clinician. Palliative care is my passion. And I went into medicine and I went into palliative care to address suffering in all its forms. And, really all its forms include, of course, physical suffering, such as pain and many other physical symptoms, psychological and emotional suffering, as well as existential and spiritual suffering. And that's the domain of suffering. Like Dame Cicely Saunders, when she started sort of the modern palliative care movement at St. Christopher's Hospice in the UK in the 60s, that's the kind of the full area. And it took me a long time to decide to become a MAID provider. But ultimately, I was really on the more, say, conscientious objection of things, can't ever imagining that I would actually hasten a person's death. But over time, I came to realize that if I was truly going to address suffering, that had to include assisted dying. Might even want it for myself when my time comes, and I don't think I could live with myself or ever ask for it if that was the case. I do spend a lot of time in palliative care, both at the University of Toronto, and I have a chair in palliative medicine and medical director of an active palliative care program at one of the major hospitals in Toronto. So that's a little bit of the background and kind of the reasons why. And I don't spend all my time doing assisted dying, of course. I'm a palliative care physician, and I use this in those special circumstances because palliative care has limitations, just as all aspects of medicine. Thank you.
Yeah, well, and I'll say for myself, it has been more than 30 years now that I've been working in the domain of advocacy as an attorney to protect and expand the rights of dying patients. And, over such a long span of time, I was campaign counsel to the first Death with Dignity initiative in Washington State in 1991. And that, is now a long time ago. And that kind of led onward to working on the Oregon campaign, which, as everyone knows, was the first successful effort. And I just found the issue so fascinating at the intersection of law and medicine that I really stayed in that domain for the rest of my career. And probably, I feel like what has motivated my work is to be constantly looking for the new frontier. And so, is that to expand choice to include an option like aid in dying? Is it advocacy to make sure patients are getting aggressive pain and symptom management? I spent a lot of time doing that work. Is it advocacy to open access to psychedelic assisted therapy, which now is showing so much promise to adding a palliative care tool to the toolbox, which has been a notable gap, and that's for relief of non-physical suffering. We've done a lot in the 30 years that I've been working in this arena to improve pain and symptom management and to make sure that standard of care is aggressive pain and symptom management, and that patients are told about hospice and they're able to enroll, and hopefully early. And that's great. And they have more choices for aggressive interventions that address pain, including palliative sedation, which is a very aggressive intervention. But there had been a gap of a tool to address non-physical suffering. And so I've been really excited to turn my efforts to that for the last couple of years. And I hope we can take a deep dive into that. And of course, Canada has also been looking at that. So we'll have the chance to kind of compare and contrast, which I think will be really interesting.
Thank you. So, I mean, I think we do want to, I think, given the way that this whole program was designed, we do want to get to MAID and maybe compare and contrast the US and the approaches, but also some of the access barriers. But before you really get to MAID, as you said, right, you want to look at the rest of the options, palliative care options, to address both physical suffering and to address existential suffering. And so I think this is right, but when somebody comes to you, Sandy, right, and asks for MAID, even though those may be the words that they utter, they're not necessarily literally asking for MAID. They're asking for help, right, more broadly. And maybe in some small subset of those requests, it ends up truly being a request for MAID. But in many cases, some other therapy or some other measure can address whatever concern that they're having. Does that sound right?
Yeah, it does sound right. I mean, some patients come to us very directly asking for MAID, but I think, before MAID even existed and we knew that this sort of acronym, this word MAID, it was really the patient coming and saying to their doctor, I want to die, I can't take it anymore. When a patient comes to me now, I hear, when they say I want MAID, I hear, Dr. Buchman, my life is intolerable, help me. And that's my cue to investigate all their domains of suffering, as I mentioned earlier, the physical, psychosocial, spiritual, existential. I think that's the competency that clinicians need to have, because you find that when you seek to address suffering in whatever forms are addressing it, patients will often accept that. And you can do a lot of good that way. And that's the importance of a palliative care approach when people are facing life-limiting or terminal illness. So, but ultimately, if that's their right in Canada, it's their autonomy that is respected. And if the patient does not find the recommended treatments, et cetera, acceptable to them, they have a right to refuse those treatments. And therefore, that leaves assisted dying as an end of life option for them.
And so, what are the other, right? The people that ask for MAID but don't ultimately get MAID. What is it that they are? What are they doing instead that they find adequate?
Well, it depends. I mean, it depends on their issue. If it's ultimately, pain or physical symptoms, those can be addressed appropriately. If there are mental health issues, depression, anxiety, that too, existential or spiritual, spiritual help, or actually opening up the discussions. It may be about dignity. we have a whole approach called dignity therapy, initiated by Canadian Harvey Chochinov at the University of Manitoba, and that's around the world. And approaching the patient's dignity as a human being can be a huge help. So there are many, many options from the physical to psychological and spiritual.
So one option, I guess that's newer, right, or just starting to get a lot more attention, is using psychedelic therapies like psilocybin. And I guess maybe, Kathryn, we should first just explain what exactly, before we get to the legal status and things, we should just explain what exactly this is and what it
Sure.
might do for patients.
Sure. Well, so, psychedelics have such a long and vast and rich and interesting history that it's really impossible to do justice on a quick program like this. I think many of us have read Michael Pollan's great book called How to Change Your Mind, which attempts a big overview of that history. It's well worth a read. It's now also a Netflix series. But these substances have been used across all cultures, across all time, across all religious traditions for a variety of purposes. And they were researched intensively in the United States in the 40s and the 50s and into the 60s. And then they were all suddenly, precipitously, in response to a really interesting confluence of events involving Timothy Leary and Ram Dass, they were all kind of pitched into disfavor with the emerging war on drugs, and they were all placed on Schedule 1 of the Federal Controlled Substances Act, which means the most strictly regulated, unavailable for any therapeutic use, and only possibly available for research purposes. And so everything about those substances went into the deep freeze for a number of years. And then starting really in the mid to late 90s came an intrepid group of modern day researchers who began the long, hard slog through new, very rigorous clinical trials with a number of these substances, including psilocybin and including MDMA. And those two substances have now moved to various stages in the FDA approved clinical trial realm. And what caused my interest to pick up was an article in the New Yorker by Michael Pollan, which was the precursor to his excellent book. And the article was called The Trip Treatment. And what it was reporting on were the clinical trial results of patients with advanced cancer. And for those patients who had refractory, debilitating, persistent anxiety and depression in the face of terminal illness, a single guided session with psilocybin was bringing immediate, substantial, and sustained relief. And I remember reading that, and it was just a signal moment where I said, that fills such a gap in the palliative care toolbox that I want to get busy seeing how to open access to that substance for therapeutic use immediately. And hence came a lot of the work I've been doing the last few years. But I think, again, and I, as an attorney and not a clinician or a researcher, my understanding is that these substances have the ability to kind of reset the consciousness of the person ingesting them. So if the person is in a cycle of depression that is, they can't get out, that this can let them step out of it. And for dying patients, it can be that the fear of death evaporates and the patient is much more at peace with what is unfolding for them in medical reality, bringing comfort, bringing peace for however long the patient has left. And, from having been in the front lines of the work to open access to aid in dying in the States for the whole beginning of my career, I can say that everyone was in agreement that good palliative care should be provided, and certainly before a patient was empowered to choose to advance the time of death. So this is another tool toward that objective, and so therefore so important.
Thank you. So, I mean, we know from the data, like when you look at how bills get passed, so when you're still in the legislative advocacy phase, everybody focuses on physical suffering, and people tell all these stories about physical suffering as the reason why Massachusetts are the reason why Maryland needs to pass this bill. But then when you look at the data in both Canada and all the 11, or at least 10 of the 11 states, when they track it, right, and they ask the retrospective data on why patients used MAID, almost never has to do with physical suffering, because hospice and palliative care are so effective in dealing with that. So as I think, as Sandy said a few minutes ago, and as you said, it typically is existential, not physical suffering that's driving the request. So I guess I just want to, so Sandy, would you, I mean, it's not yet available, I guess not really available in the US either yet, but would you welcome this as a palliative care physician as an additional tool short of MAID to help patients deal with those symptoms?
Yes, I would. You know, based on sort of the approach that I take before to addressing suffering, and with the promise that psilocybin-assisted therapy can address existential suffering, I think it has the potential to be an incredible tool in our end-of-life toolbox. And so, yeah, I would very much welcome it. We haven't had the same opportunities to use it in Canada. At this stage, it's not readily accessed. It's controlled, and when I've tried to get it for my patients, it's strictly been for patients with cancer, and that's where our studies are being done. But so it's not yet as widely available. So it's very difficult to comment on not having much experience so far with it. But it's incredibly promising, and it could be helped. But it's not, just like everything, it's not going to answer all the questions. Existential suffering certainly is a part of the request for MAIDs. There are many others, such as, you know, certain personalities or personality types. You know, we look at the demographics of who request MAID, and it tends to be people of higher socioeconomic status, often white background, and those people who have had lives or careers where they have a sense of control. They're CEOs and lawyers and physicians, might I add, who are requesting. So people who had a sense of control in their lives. And so those psychological factors and personality factors are also critical. And they are more common than the sort of the physical suffering or even the psychological suffering that people experience. It's often about dignity.
So we, in terms of experience, I guess maybe Kathryn, you could tell us, in 1994, Oregon became the first jurisdiction to allow medical undying, and it appears that Oregon may similarly be the first jurisdiction where we're going to get some actual experience with psilocybin and therapy. Is that right?
Yeah, well, so Oregon once again has stepped out as a pioneer in forging a path, as it did with aid in dying, to be the first state to create a state legal regulated program for psilocybin access. And that was passed by the initiative process, as was the Dignity Act back in '94, by direct democracy at the ballot by the voters. And interestingly, built into the measure was a 2-year preparation period where the Oregon Health Authority was called upon to bring together stakeholders to develop a regulatory program. And so there's been a lot of meetings over the last 2 years to determine things like, you know, who will be eligible to be a facilitator? What will the training be required to be a facilitator? Because it is not a dispensary model. The model that is adopted in Oregon and is now being mimicked in other states, including Colorado, which has a ballot measure this fall, is that there is a preparation session before any administration of the drug, and then there is an administration session that takes place at a service center. And put a pin in that, because there is a disability rights issue about mandating that services be only at the service center, in the presence of a trained facilitator. And then there is to be one or more integration sessions following. And so that's the model. And so the OHA in Oregon has been working on the rules for all of that. And everyone involved will have a license from the state. And all of this is to begin operation in 2023, which is now right around the corner. So we don't know, how it will go in Oregon. There's tremendous excitement about it. We don't know. A big question is what will be the posture of the federal government, because of course psilocybin remains on Schedule 1 of the Controlled Substances Act. And so we haven't had a signal from the Department of Justice or from the DEA about whether there will be enforcement or whether there will be what lawyers sometimes refer to as a cooperative federalism approach, where if a state has chosen to legalize and regulate, the federal government will adopt a policy to refrain from enforcement. Of course, that eventually happened in the cannabis arena, although, through a DOJ memo, which of course is not a particularly safe harbor because it can change, and it did change when the leadership in the DOJ changed, when the administration changed. And so we don't know what will happen in Oregon, but I think there's a lot of excitement that the experiment there will be allowed to unfold. And it could be an opportunity to develop data on, for example, a really interesting question, which is whether patients who have interest in aid in dying as an end-of-life option, whether that interest would be impacted by psilocybin-assisted therapy. And there have certainly been thought leaders in the palliative care community here in the States. Ira Byock, who's well known to many who are in this arena as a thought leader, a former president of the American Academy of Hospice and Palliative Medicine, who's a big advocate of psilocybin-assisted therapy because he's an opponent of aid in dying. And he hopes that opening access to it will undermine or eliminate interest in aid in dying.
Right. So but let me make sure I got that. Notwithstanding the uncertainty about the federal status, Oregon not only passed the initiative, but then created a gigantic regulatory structure and multiple agencies in the state government giving licenses for manufacturing, for delivering it, and so forth. And then of course, a lot of people are making a lot of big investments, right? I mean, establishing these centers and so forth. So people are going to move forward, notwithstanding that uncertainty, right?
Yeah, they seem to be moving forward with a lot of excitement. Training programs are being announced every day for facilitator training. One interesting aspect is that the Oregon law does not require any educational credential to be a facilitator beyond a high school diploma. And then a module of training that the OHA will determine necessary for licensure. So, again, for those interested in the care of patients with advanced illness, query is that serving that patient population, would it be desirable and optimum to have someone like Dr. Buchman, who knows the complexity of patient with advanced illness and perhaps all the other medications they're on, whether they have issues with assimilating medication, et cetera, to be giving care to that patient. But that is not the Oregon model. Very low barrier to entry to be a facilitator, and actually a huge barrier to entry if you are a credentialed palliative care physician, because remember, those professionals hold DEA registrations. And if they run afoul of the CSA, there can be licensure consequences and registration consequences. So while you might hope a dying patient could see their palliative care physician for this care, there's that barrier. And hence the work with Right to Try, which would create a federal as well as a state safe harbor.
So, right. And I guess, I don't know if Sandy could comment on this, right? But one might think that it would either be a palliative care specialist or maybe even somebody with psychiatric, since you're literally guiding them on the trip, right? But you're saying that it's going to be a completely brand new license category, which would not require either a board certification in hospice and palliative care or board certification in psychiatry or anything like that. It would just be this whole new license, and it doesn't really have the floor is rather low on what you need to get that license.
Yeah.
I don't know if does that Because I guess, Sandy, you were saying that, you know, for some, you do refer out some of your patients for mental health counseling, and that would go to a specialist because maybe you don't do that yourself. So I guess for this, if you had psilocybin in Canada, I guess you would send them to, or if you moved and restarted your medical practice in Oregon, then you might send them to one of these centers.
Yeah, I know. I imagine that. I mean, early on, we would send them to one of these centers, and I think the importance is understanding that it requires the facilitation for you know, resolution of the existential stress. It's not just the psilocybin, you know, but it sort of strikes me as interesting to hear that there'd be these barriers for palliative care clinicians or others too. To face it, we do so much more. You know, we're doing palliative sedations, we're providing assisted dying, yet we wouldn't be permitted really to, you know, to do psilocybin assisted therapy. It's very interesting and kind of ironic that that would be the case.
Right. Well, I mean, if I might say, I think you're exactly right there, which is I often pause when I'm talking on this topic to remind people that, you know, we do empower dying patients with the choice to ingest controlled substances to eradicate consciousness. And that's the intervention known as palliative sedation. And we empower them to ingest controlled substances to precipitate death where aid in dying is available. And so shouldn't we allow them access to a controlled substance which elevates and expands consciousness, which is what is reported to occur with psilocybin assisted therapy. And so, yes, I quite agree with you.
And it's not that the palliative care physician in Oregon would be prohibited. It's just that they might be deterred or chilled because of the DEA, right? Would this be analogous at all to back in the Gonzalez case, right, where the DEA and the Department of Justice said that all you guys prescribing medical aid in dying in the state of Oregon are violating the Controlled Substances Act? I don't recall whether that chilled or deterred participation with death with dignity because they might be afraid to prescribe that. Is that what you're suggesting?
Right.
Is something similar is happening now?
Well, I mean, certainly when the U.S. Attorney General issued the directive that any clinician complying with the Oregon Death with Dignity Act would be at risk of federal prosecution due to violation of the Federal Controlled Substances Act, I think it did create a chill. But as you know, we sprang into court immediately, into federal court, challenging that as an unlawful intrusion and overreach by the federal official into the regulation of the practice of medicine, which is largely left to the states in the US system. And we were successful at every level of federal court review, district court, Ninth Circuit, Supreme Court of the United States. And that precedent actually does have some considerable bearing in the right to try litigation that I'm involved with now, which is seeking to compel the DEA to permit access to psilocybin for therapeutic use. Because again, what we see is a DEA overreach that is intruding into the regulation of the practice of medicine. And hence we saw so much interest among the states in participating in our RTT case as amici. And we saw a lot of states come in to take that issue up as a matter of federalism. But I don't think it so much relates to the operation of the Oregon Psilocybin Services Act, because that act, remember, it disavows medical use. The Oregon law is an adult use statute. You need have no diagnosis of any medical condition to have access. And that was explicit in the law. So the so-called healthy normal is able to access psilocybin services. And I think the disavowal of a medical use kind of takes away a potential to use the Ashcroft-Gonzalez case effectively in Oregon to protect the Psilocybin Services Act. But it is useful to us in our right to try litigation.
Okay, and then just not to get too technical on the legal side, but it sounds like you on the state law side, you have the statute, you have the regulations, they're being implemented, but it's this federal side that you're trying to clarify or eliminate the cloud of uncertainty, both through suing the DEA, but also you have a bill in Congress to basically accomplish the same things. And those are both in
Well, right. I
progress.
mean, I think for the listeners, it's important to disambiguate, what's happening in Oregon under its state statute is purely a state permission. Whether or not the feds will try to disrupt that, we don't know. Entirely separate from that, and it really is because when I was working to help the campaign pass the Oregon Psilocybin Services Act by bringing voices from the end-of-life care community forward, because they are powerful voices, it occurred to me that there would only be a state safe harbor, and hence I was casting about for how can we find federal safe harbor as well, and came to see these right to try laws, which are really interesting. I don't believe Canada has anything similar. So in some sense, the US may be actually ahead of Canada when it comes to psychedelic therapy access, whereas it is behind Canada when it comes to access for aid in dying. And that's interesting. But in the US, there are these state laws called Right to Try Acts and a federal Right to Try Act. And they swept the country like a firestorm. They were enacted between 2015, 41 states adopted them, usually with either unanimous or very broadly bipartisan support. And the basic notion of right to try laws is recognizing that patients who are dying don't have time to wait for the long, slow process of new drug approval to complete. And so for that population, anyone with a life-threatening illness, access to an investigational drug should be permitted if that drug has passed a phase 1 clinical trial and remains under investigation. And that is true for 2 psychedelic drugs, psilocybin and MDMA. So it is intended by already enacted US law that therapeutic use of psilocybin and MDMA be allowed for that population. And so seeing that led to our work to approach the DEA and say, did you know about this law? How are you going to accommodate it? And the DEA apparently didn't know about it, but said, we're not going to accommodate it. And so we've taken the DEA into court, and we've now had one round of litigation that focused very much on the question of whether the DEA's determination was sufficiently final to open the courthouse door, which is an administrative law prerequisite to having judicial review. And we went through a full litigation about that. We had to go back to the agency to extract a more final agency action, which we did over the summer. And so now we're back in court where the courthouse doors are now fully open and we should be able to reach the merits. And we have a strong merits argument. And also our first round of litigation precipitated a bipartisan bicameral introduction in the US Congress of a bill to clarify that the Federal Right to Try Act does encompass Schedule I substances, because that's sort of the DEA's merits argument, is that Schedule I substances are special and they're not part of right to try. So a real benefit of our first round of litigation was the stimulation of that federal bill. And I just will flag for your listeners that, there is an opportunity to participate in that federal legislative effort by putting in letters in support to your federal electeds and copies to the sponsors, because that can help those federal elected people do their job and enact an important clarification of the right to try bill.
Do you have the bill number?
I do. I could put it in the chat while we're talking.
Yeah, just, if
I'll
people want
pull
to
it
write,
up. Yes. Yep.
Let
I'll
me,
put it in the chat.
Okay, great. Let me try to pivot back to MAID. Actually, before I forget to lose this thread, Sandy, I think you said in the first 5 minutes of the call that you were initially reluctant or hesitant to become a MAID physician. So I'm just wondering because I think if I'm right, it was first in 2016 that Canada that was C14, and so I'm wondering then how far, I guess, later did you decide, yeah, I will, and what was that process?
Well, it actually just happened earlier. As we were anticipating the Supreme Court of Canada Carter decision in 2015, we have a very large group, one of the largest North America palliative care physicians who are working together. And of course, more than 20 or 25 of us, we were all kind of all over the spectrum, all over of whether we would participate in assisted dying or not. For a physician of my demographic, it was an anathema to us to consider ever being involved in hastening death. Couldn't even imagine it. As a matter of fact, I remember thinking when patients asked to die or to hasten death, I selfishly felt, wow, I'm glad I don't have to deal with this, that there wasn't an option in a selfish way, if you know what I mean. But we organized a process among our team because we knew we were going to be approached with requests for assisted dying. And we had everyone from conscientious objectors, right, to those that were quite open to it. I found myself on the more conscientious objector side. And just because it was so unknown and it took a lot of time. It took a process that we developed with mutual respect and just valuing everybody's opinion without judgment to get me to a point that I felt that, again, as I mentioned earlier, to really truly address suffering in all its forms. Ultimately, it's and respecting the patient's autonomy to make their decision, and that I would participate in the process. So by the time the Bill C-14 came about in February of 2016, I was ready to consider providing assisted dying. And it's quite public in a Maclean's article, a Canadian national magazine called Maclean's in 2017, where my first patient was a professor of cardiology. And he and his family went very public about it, wanting to share what their experience was in assisting MAID and in receiving MAID. And so it's really from then on that I've recognized this as an important aspect of practice, an important treatment option for patients in this country. Again, I do what I can to, how shall I say, it's not a dissuade, but look at every possible alternative to assisted dying, but ultimately respecting the patient's decision if that's where they want to go.
And maybe it's not strictly binary, which is like you're a MAID physician or you're not a MAID physician. I'm wondering if you've had a patient who actually is eligible, so they would meet the eligibility guidelines. Nevertheless, you personally didn't want to be their clinician for that purpose. Did that ever happen, or or your own personal comfort level sort of aligned with the law, such that if they're eligible under the law, then that's then you're comfortable with that?
So as I think you're aware, we have after C7 was passed in March of 2021, this offered a second track to MAID. So track 1 is for patients whose death is reasonably foreseeable. It does not specify a prognosis like 6 months or a year, but the trajectory or the pathway has to be towards an inevitable death. So that's reasonable, foreseeable, natural death. The patients with disabilities, long-term chronic diseases, applied in Quebec for, it's called the GLADU decision, and state that our suffering is intolerable as well. And so ultimately a new track was created, now called track 2, which allowed medically assisted dying for patients who had a grievous and irremediable medical condition, but were not on a track towards reasonable foreseeable death. So in other words, non-reasonable foreseeable death. I have personal challenges in providing assisted dying for patients in track 2. That's just a personal decision of mine. You can say I'm a conscientious objector on track 2 as opposed to a conscientious provider in track 1. And those are personal. I respect the complete rights of patients on track 2 to access MAID, but I think there is a line for every individual. I have issues with Canada's struggles with providing adequate healthcare resources, supports, access to healthcare and to expertise in healthcare, financial assistance, etc., that I think sometimes initially drive the patient's request for MAID. But they're really sort of, they don't happen all that much, but it's still possible to happen. I think actually there's many patients who we're having a controversy now in the country where patients are saying it's easier to access MAID than it is to access the healthcare resources and supports and financial assistance and adequate housing, et cetera. In other words, many of the social determinants of health. And I think that's a huge issue. But the problem is not so much in the MAID legislation, but in the lack of equitable access to these resources. So I struggle with that.
Thank you. So, and just to be clear, even under track 1, which is the more restrictive track and the track that you're comfortable with, the term is, as you said, is reasonably foreseeable natural death, which doesn't have a temporal definition. And I guess it's probably, we should probably do this since we have, is Kathryn, I mean, you should, if you could just quickly give us a recap of what the basic eligibility conditions are in the US, which are dramatically different than what they are in Canada.
Yes, and of course, it's hilarious that you're asking the question because no one knows better than Thaddeus Pope. So really, I'd much rather you do it, and it's a little embarrassing to be called upon, but please correct me. How about that?
Well, as you said, you were there on the ground in Washington and
Yeah.
Oregon in the early 90s.
It's true.
You
I
were
mean, it's
there.
true,
I
but
wasn't
you
there.
have been such a scholar. And, you know, what I really appreciate about your work, and I want to shout out for everyone, that your scholarship is impeccable. And what I really value is your constant comparing of the different statutes because they are different. They all have little differences. And many people don't do a deep enough drill down to understand what those are. And I think you've done a great job of clarifying. But in general, they mostly require that the patient have a life expectancy of 6 months or less, that they have decision-making capacity about medical decisions, that they are able to self-administer the medication. And then there are a host of sort of procedural requirements around making a request in writing and having that request witnessed, and then having a duration of what's referred to as a waiting period between a first and a later second request, and on and on. So it's procedurally very burdensome for the patient. And, you know, we certainly hear about cases in the States where the patient waited until they were in extremis to initiate the process. And then the waiting period was so long that they died during the waiting period. And that, of course, has now given rise to a spate of effort to shorten up waiting periods that has had some success. And so that's the general sort of set of requirements. And I hope we'll get into it, but we can also talk about the particular self-administration requirement, which poses an interesting problem for people whose terminal illness imposes progressive disability, where need for assistance with completing an ingestion of the medication is required for the patient to be able to access it. And we can talk about that case that's pending in the California federal courts.
Yeah, maybe we should talk about that. So maybe just get Sandy up to speed, right? So I think this is right, but maybe there's been around 20,000 MAID deaths in Canada, maybe about 12 of which were through self-administration, right? All the rest were clinician administered. But in the US, it always must be self-administered. It must be the patient herself. And some patients with advanced ALS just literally can't self-administer. So I guess maybe I should, before we get to that case, I mean, why would somebody want to self-administer in Canada if they had the option of clinician administration?
So I'm not sure. So few offer it. The potential complications are greater, of course, with say vomiting, et cetera, aspiration, those kinds of things. It takes much longer. You know, the IV administration of medications is pretty fast, you know, within minutes, right? And so virtually everyone chooses the IV administration option. So I have patients, you know, and it's typically the ALS story that could not self-administer, and And I just might want to add that the existence of the MAID law has actually allowed many of my patients to accept palliative care. One being a HIV positive 44-year-old man with advanced ALS who had no use of his hands. He could walk, but he required feeding, he required assistance with toileting and dressing, etc. And he lived on the 22nd floor of a high-rise apartment building in our city and told me very clearly that he, with a chair out on the balcony, that he would go over the 22nd floor if it wasn't for the existence of the MAID law that gave him a future escape. And I would like to comment as well, the fact that it's a trajectory towards death and not a specific time frame prognosis is also a really important factor. Prognosis can be the worst art and the worst science. It's more typical in cancer patients where you can be more predictable. But this ability to have a reasonably foreseeable death in patients with other diseases makes it far more reasonable, and we don't get into the problems of having to wait or cause a person to endure suffering for a longer period of time. But again, it's using the lethal injection method is a far simpler and I think a safeguard. Actually, I would worry if I wasn't there providing oral medication to know, and in certain jurisdictions this is the case where the physician doesn't have to be there and the oral medications could be shared with others. As an example, maybe not giving sufficient dose and leading to maybe potential vegetative states of one or the other, problems like that. So I think for that reason as well, most people prefer IV injection.
So from a patient safety perspective, it's more effective, fewer side effects, less risk of abuse, is what I'm hearing. And what's interesting, of course, in the US is the state of California, for example, says no, self-administration is really, really important because that gives us the confidence that this is truly a voluntary decision. If the patient doesn't do it herself, how do we know that it was truly voluntary? I don't know if you have a response to that.
We have a lot of ways to assess whether there's a coercion involved at all. And remember, the patient has to give their consent right up to the last moment. I apologize to my patients for bothering them so much about whether they proceed where we can withdraw at any time and with no consequence to the patient, really total reassurance. I can't see that that's actually a factor. I understand the theory, I understand the argument, but in reality, that's not the case. These patients want to proceed and they are very definite. Canada even got rid of the 10-day reflection period. In Bill C-14, we had a 10 days before we could administer MAID just so the patient could pause. No one ever changed their minds. And so people are certain that they want to proceed with this. So now we don't have that reflection period. As a matter of fact, we have a waiver of final consent. So if a patient is found eligible, they can sign a waiver of final consent that would allow a physician to administer assisted dying if that patient lost capacity before the date that they were scheduled to have made. And I think it's been a very valuable amendment because before many people chose assisted dying long before they absolutely needed it, fearful that they would, say a patient with brain metastases, an example, fearful that they would lose capacity before the procedure. They would miss events in their life, such as Christmas and everything else, in order to ensure that they were to receive assisted dying.
Right. So Kathryn, we heard earlier in the previous session in this conference that Kevin Diaz at Compassionate Choices and Nick Diance, Portland, Oregon physician, explained how they basically successfully challenged the residency requirement, which exists in all the U.S. MAID laws. And you have a lawsuit which is challenging, at least partially, this self-administration requirement, which exists in all the U.S. MAID laws. I mean, so if you could just give us a quick recap.
Sure. Well, first, I have to say, when I hear Dr. Buchman go over all of that, it just once again strikes me how progressive Canada is and how very, very far behind the US is. And it's just it's really difficult, and I don't see any possible solution to that anytime soon. Particularly, at the introduction, the Glucksberg and Quill cases were mentioned, which would have created a national access to aid in dying under the federal Constitution. And when those cases were decided back in 1997, the court was very careful to reserve the possibility that it might in future find such a right, as the two federal circuit courts of appeal below had found. But what's happened in the interim with the shift in the composition of the US Supreme Court is there's no possibility that that would ever happen, and no one would be prudent to take an individual liberty, privacy, equal protection claim of that nature back to the SCOTUS. And so we're left with a patchwork of state laws. The state laws do include a self-administration provision, and bringing focus to California. And again, of course, you are the expert on the comparing of the different state statutes, so speak up. But, California has two provisions in its statute at issue here. One is a requirement that the patient self-administer, and self-administration is defined as the patient making a voluntary, conscious, and physical action in ingesting the aid in dying medication. Patients with ALS can often do that. They can make a voluntary, conscious, and physical movement, some of them. And yet their advancing illness may prevent them from completing that act. And the second part of the California law, and the part that we have specifically challenged, we have not challenged the self-administration provision. What we have challenged is a second provision that is a prohibition on assistance with ingestion. So there's a second piece in the California statute that says no one may assist the patient with ingestion. And so our case focuses very narrowly on that, because there are many patients with conditions. ALS is one of, I am told, 10 motoneuron conditions that could impair the patient's ability to complete an ingestion, even though they could initiate it. So, what my physician clients in the California case tell me is that many of the patients with these conditions will be ingesting medication through either a feeding tube or a rectal tube. And that mode of ingestion involves the depression of a plunger on like a syringe that has the medicine. And that the patient with these conditions could start to make that depression to deliver the medicine, but they maybe couldn't complete it. And the physician clients want to know that they can assist the patient in completing the depression on the plunger so that the full dose of medication is delivered per the patient's desire. So that's the case that we have pending in California. And I will tell you, and this probably horrifies Dr. Buchman and maybe many in the audience, we are met with very robust objection by the state. It did not cave as the state of Oregon caved in the Dr. Gideon's case, because of course that was a very easy case. It was obvious that there was a violation, and the state just agreed to not enforce that provision. In our case, the state of California is aggressively defending. We've received notice that some disability rights groups, amazingly enough, are going to come in as amici defending the state. And, the really perverse thing about the operation of this California law is that for patients in this category, they feel a terrible fear that their window of opportunity will slam shut and they'll be trapped. And they feel pressure to act sooner than they might want to. And this just happened for us. Our named patient plaintiff was a relatively young woman in her early 50s with advanced ALS. She had a very beautiful, happy family with 3 young adult children. She wanted to spend every possible moment with that family before her illness took her. And she had a tiny bit of movement left in her thumb. And she chose to go sooner while she knew she could still depress the plunger. She wasn't ready to go. She was deprived of a quantum of life with her beautiful family. And it's heartbreaking. And so that's the case that we're bringing forward. And of course, now we had to scramble around and bring in a new patient to keep the case going. And it's really difficult because, of course, patients die as these cases go forward. But we'd like the cases being litigated through a disability rights lens. It is an ADA claim, an Americans with Disabilities Act claim, which requires reasonable modification to ensure that people with disabilities are not excluded from access to programs and rights that other people who don't have disability are able to enjoy. And so it's really quite interesting to see some disability rights groups coming in to oppose the reasonable accommodation. And it, I think, reflects the deep, deep animus that some disability rights groups have to the notion of empowering dying patients with this choice.
Thank you. I see we're coming up to I see a lot of questions in the Q&A box, and I know Sarah's going to want to get to those. But let me just make one last point, which is, in addition to doing what you just described in that California case where you're attacking the legal rules themselves, there's another approach, which is there are people who cannot access MAID even under the existing rules because sometimes because the facility where they are asserts a conscience-based objection, or and I know that you've brought suits like that, Kathryn, but I wanted to ask Sandy about MAID House and what MAID House is and why you helped found that institution.
So thanks for that question, Thaddeus. MAID House is a facility that I founded about 3 or 4 years ago, which is basically an independent facility where patients can go to receive assisted dying if home or hospital or whatever is not suitable. So like the US, we have many faith-based institutions in Canada that do not permit assisted dying on their premises, and even at times do not permit assessment at all within the hospital walls. I also have a long history of working with those experiencing homelessness all along the continuum in the inner city part of Toronto. And home is not always available nor suitable to have this procedure done. Often if patients did want assisted dying, and it's actually, as I mentioned earlier, it's more a choice of those of higher socioeconomic status. But for those who did not have a home or home wasn't suitable, needed an option. Often hospitals were resistant to bringing in patients, and it was often done in a very clinical, operating procedural room type of environment. So coming from the palliative care world, I'm actually developing a new hospice residence in Toronto area, but I wanted a facility that could provide that sort of patient and family centered home-like atmosphere where assisted dying could be provided to really respect people's choice and provide equitable access to care. It's become, it is a center where MAID is provided, quite home-like and lovely. It's also become a source of research into assisted dying, grief and bereavement, for example, as well as education training facility.
Thank you. So I know that we promised that we were going to take the participant question, and I think, I hope my understanding is right, Sarah is going to come on. She has selected or read the questions and was going to read them.
Indeed. Thank you, Thaddeus.
There you go. Okay.
in the process of joining the stage here, so give us a minute. There we are. Hello, hello. Thank you all so much. This has been a fantastic discussion, and we have some great questions coming in from the audience. So without further ado, first up, question for Dr. Buchman from Ali. He's wondering what draws the limits or defines the lines of existential distress, both clinically and perhaps legally within the Canadian law. And Kathryn, after Sandy replies, feel free to jump in as well.
So I'm not sure if I can put strict parameters or boundaries about what existential distress is. It's you know it though when you see it. Patients who are struggling with their mortality, fear of dying or fear of the time after death. Can also put people who struggle often with spiritual or religious issues, kind of those questioning of, why me, God? Why has this happened to me? What did I do to deserve this? It's those kind of questions or clues that would tend to lean towards exploring whether that distress was existential, facing one's mortality in all its respects, I think is a way that would lean us towards pursuing existential distress. Obviously, you'd have to rule out other significant mental health problems, other types of anxiety disorders, depression, etc. But often they have this component of facing one's mortality is the kind of way I approach it.
Yeah, I mean, I'll just comment. I've found it incredibly interesting and informative to look at what patients in the clinical trials in the States with psilocybin-assisted therapy have spoken to as, what they were suffering and why they wanted that therapy and how the therapy brought them relief. Because it's a real window into what is existential distress for these particular patients. There was a really wonderful 3-part podcast recently aired by a group called My MBC, which stands for My Metastatic Breast Cancer, on psilocybin-assisted therapy for people in the MBC community. I think you can just Google it up and find your way to that series. And there were some patient interviews that were incredibly compelling, including by my client, Erin Balderschweiler, in the Right to Try litigation. And I'll just share a little bit. I mean, she's a young woman. Again, she's just turned 50 with stage 4 cancer. She's a single mom with 2 children at home, and she does not expect to see those children into adulthood. And that is giving rise to a lot of distress for her. So the stories are very moving, and, an experience with a therapeutic modality that enables the patient to feel at peace with what's unfolding is really critical. And that's what psilocybin-assisted therapy offers. And I should mention also, to those interested in the Right to Try work, you can also Google righttotrypsilocybin.com, and it has a website with the law. I mentioned those federal bills. You can sign a petition there. You can learn more about the case. You can tap on a donate tab to support the case, because of course, that kind of advocacy, public interest advocacy, is not free, and we welcome support for it.
Thank you both. So it raises an interesting point about mental illness and mental health disorders as a tricky subject regarding the end of life. And I'm curious, this question is for both of you. On the one hand, I know that the mental health as a criteria for eligibility for MAID is coming up within the Canadian legislature in the coming few years here. And also, to the point of psilocybin, it could, it's demonstrated to alleviate anxiety and depression in patients. So I'm curious if both of you can talk a little bit about mental illness, perhaps by point of example, and where you see the future of this heading.
I guess I can jump in first and just to update our participants on what's happening in Canada. This has been going on for many years, and finally, through the review of amendment to Bill C7, which became law in March of 2021, that by March of 2023, mental disorder as a sole underlying condition, in other words, no other associated conditions such as those might have reasonably foreseeable death or chronic disability, but mental disorder as a sole underlying condition can be a criteria for accessing assisted dying. And so that's what we're facing in March of 2023. And it's a difficult road. They have had, some of this has been available already in some of the Benelux countries like Netherlands and Belgium. But this is the first time we're facing it, and we're seeing, both. We're seeing both advocates for and many professionals within the mental health field who are against it. Is psychiatric illness or mental health truly irremediable? So if we have to meet the definition of grievous and irremediable medical conditions, there's always potential hope or things that some things may change. So that's our current state right now. A person can access assisted dying if they have, say, on track one, reasonably foreseeable natural death, and a mental health problem. That's an issue. They're capable of doing that as long as they retain capacity. But we're facing this future with mental disorder as a sole underlying condition, and it's still quite unknown to me and many others at this point in time.
Yeah, I mean, again, Canada is so far ahead of the US that it's hard to compare. But, certainly for people with advanced illness, it's understood that it's common that people are going to have very normal, expected bouts of depression and anxiety and distress about that reality. And that's should not preclude people from being eligible for any of the end of life choices unless they are unable to process information and make informed, competent decisions for themselves. That's sort of the dividing line. So I think that's where we are, and that's where we should be.
Thank you. So Marcia is wondering, many in the US would like to see MAID available to people with dementia who do not currently qualify for it. And Sandy mentioned earlier I believe the waiver of final consent. Yes, thank you.
It's not advanced consent, right? It's not
Right.
Advanced request for consent. It's a different issue. Yeah.
So she's wondering, any thoughts on what it will take to achieve this? In the US, I see Thaddeus shaking his head, and I see why, but perhaps you can elucidate given the current restrictive requirements.
Let me just say it real quick, right? I mean, it would eliminate a whole bunch of the current requirements, right? So one is, if you're really requesting it in advance for late stage dementia, then it's not going to be self-administered. Somebody else is going to have to administer it. So that means that would require the US to jump from self-administration MAID to euthanasia, which no state is ready to do. Secondly, we currently require a contemporaneous request with capacity. This is doing it through an advanced request. So it's too many, right? It's a dramatic change of a whole bunch of the current regulatory requirements. I'm not saying that it's wrong. I'm just saying it's so dramatic. We're taking away, as we heard, the residence requirement and the assistance of self-administration, maybe. But I just want to point out that what the question was is something way, way bigger in terms of how big a change it would be from where we are right now.
Yeah, I echo that, and I don't see it happening. And so I think where we're left for people who worry a lot about persisting with advanced dementia, again, many organizations have developed good, specific, specialized advanced directives for dementia where, the directive is no food and fluid by any means, and no medical intervention of any kind, and maximum comfort care. And so, at least that can eliminate the concern about being kind of persisting with advanced dementia where you've been given a feeding tube and you could live another 10 years. You will be able to achieve death within a relatively short period of time in a comfortable state.
It is. I mean, maybe Sandy could comment on this, but one other thing is, you can do advanced directives for dementia in the Netherlands, and Canada has been discussing this, but multiple survey evidence indicates there are very few clinicians that are comfortable doing that. So changing the law is one thing, but then finding a clinician that's willing to show up in your late demented state to give you the IV is a practical problem. And so I think that's just something else to think about.
100%, if I may just compliment, if I have a patient who clearly stated in their advanced request, when I can no longer recognize my loved ones as an example, or if I require assisted with toileting as sort of a dignity issue, I want medical assistance in dying. First of all, even in Canada, no one other than the patient can decide. So a substitute decision maker, or what we call power of attorney for health, cannot decide for another person. They can decide all other medical treatment, but they cannot decide whether the person for whom they are the substitute decision maker can have assisted dying. If I was to be participating in that and the patient resisted, a demented patient resisted the IV, or I'm not going to trick them into taking an oral medication. If they resisted in some way, would I still give them the injection? I'd have to force them down to put an IV. It's completely unethical and anathema to almost every clinician I know. The other issue, of course, is a more existential one. Are we the same people? If we, at this stage of my life, if I can no longer recognize my loved ones, and how do we actually know that is another thing, because suffering is very personal. But is that, if I'm happy in my dementia, if I'm comfortable, if Cassell's did a lot of the research on this area and talked about an individual having to really a person has to have the sense of the past, of who they were and what the quality of life was, and a sense of the future. And many people with advanced dementia, of course, are living in the moment. They do not remember their past and who they were. They do not remember anymore or can think of a future. So if they're comfortable in the moment, they're well fed, they're looked after, they're clean, they're emotionally comforted, would they still want MAID? So I think there are many issues that are disturbing to us, with still that dilemma of recognizing that so many people are advocating for advanced consent. But there's two people in every MAID procedure. There is the patient, of course, and the clinician, who are actually involved, in addition to loved ones and family. So I think there's a great resistance that the clinicians who would provide it would likely be few and far between.
Yeah, I mean, what you just said, Sandy, reminds me of the really good writing that the legal philosopher, who's now gone on to his next lifetime, some years ago, Ronald Dworkin, had in his reflections about this very issue. And I think it's some of the best writing about it still to this day. And, he really calls on us to think about, in that situation, is it the person who thought they wouldn't want to live with persistent advanced dementia, whose rights we recognize when that situation arises? Or is it the person who now has persistent advanced directive, who may be apparently content? And which are you respecting? Because it may be that the appearance of contentment would still be an affront to the person who would never have wanted to persist in that state. So it's a really interesting philosophical debate. Yeah.
Is it the same person? Is there continuity of personhood in this, is kind of the real question.
Right. I mean, I'd also like to give a tiny shout out to the group in the States that I think is doing a tremendous service for the community of clinicians who do practice aid in dying, and that's the American Clinician Academy on Medical Aid in Dying. And the reason why I mention them is, I think they are doing the hard work of clinicians to develop best practices in this arena. And, because the practice is still somewhat in stigma, one might say, even though, now we're more than 25 years from Oregon pioneering the practice, they have a great, lively discussion that's constantly ongoing about evolving and improving the practice. And it's really a very wonderful service.
Absolutely. And thank you, Kathryn, for mentioning that. Lonnie Shavelson is a friend to the Completed Life Initiative. He's been on a program in the past, so I'm happy to have the shout out as well. So two questions are overlapping, and it really drives at a central question that our audience is likely to be itching to answer themselves, regardless if they've seen the question or not, about does Canada have a residency requirement for MAID? Because given the somewhat restrictive laws within the United States, you know, many are wondering what would it look like if they wished to travel to Canada for more expansive support regarding MAID?
The answer is yes, there's a residency requirement. So they have to be receiving healthcare services in Canada and, of course, be over the age of 18. Those are two criteria that are pretty strict. It was to discourage medical tourism. It's going to be different for abortion now that Roe versus Wade has been defeated. But so people will be coming to Canada for abortion procedures, but not for MAID.
I'll just supplement and say, really, the one jurisdiction in the world that has both expansive eligibility requirements and no residency requirement is Switzerland. So people go either to Zurich or to Basel, to Pegasus or Life Circle or Dignitas, because you have both of those things: broad eligibility requirements and no residency requirement.
Thank you both. So our next question is from our friend Rebecca Brown up in New Hampshire. She's wondering, her fellow colleagues in New Hampshire are considering proposing MAID legislation that drops the 6-month requirement for in favor of a reasonably foreseeable death, at least, and potentially eligibility more like the Canadian Track 2 that you mentioned, Sandy, earlier. So do you think this would be helpful for the death positive movement, or perhaps harmful, or more of a both and? What are your thoughts?
Well, I mean, reasonably foreseeable is a squishy term, which I think is advantageous in the sense that an interested patient and a willing physician, could decide to go forward without a rigidity of the 6 months. So I think it is probably good. I think the less rigid is desirable.
I might just add that I've only worked in a system that had reasonably foreseeable natural death, as term. So it's hard to comment. Again, from a clinician perspective, I think it's difficult to always know how long a patient will live in non-cancer related diseases. And so, we have patients with excellent palliative care who could live a lot longer than their anticipated prognosis, just the nature of these diseases. And when we're addressing so many symptoms and improve general well-being and nutrition status, et cetera, people can live longer. They're watched carefully. So I find it, that I would have to delay a person's assisted dying until 6 months or less, difficult to predict. And at the same time, thinking as the case that Kathryn mentioned earlier, where they would have to have a procedure earlier rather than later. Like I think it's important to look at the patient's life and what they want to live for, and it may be that a patient reaches a certain point that would be before the 6-month range where life is intolerable, where suffering is intolerable. And I think, therefore, that as long as they're on that trajectory towards that, towards death, that then we have the ability to provide is a much more humanitarian and compassionate approach.
It is important to remember how the U.S. model works, which is that would only get you the eligibility to get the prescription, right? And then you could pick it up. Many people never take it, right? So all this is access to the prescription, and maybe, just in case, right? Just in case your symptoms later become intolerable. But many times it doesn't, and many people never take the prescription. So I think, the New Hampshire proposal would expand access, but not necessarily usage, because all it does is get them access to the drugs. Whether they take it is a completely separate question.
You know, we have a similar issue. Many patients want to kind of know that they're eligible, that they've been approved, their eligibility has been approved. It's kind of like a back pocket. They keep it as an option in the future, even if they don't want to do. I have some issues because is their suffering truly intolerable, which is what we have to sign off on for eligibility. Is their suffering truly intolerable if they kind of just want it in their back pocket? So I will often tell people who aren't ready and just want it, I said, you know what? When you're ready, you need to come back and see us, and we'll talk about your eligibility at that time. Because if there's a sort of hesitancy, you know, right then, that it's more just reassuring that they're eligible, then I have to really, I can't really fully accept that their suffering is as intolerable as they say it is. And remember, suffering is subjective. As an outside person, I cannot determine, you know, objectively suffering. I have to accept what the person says it is.
Well, thank you all so much. I realize we are out of time for today. Unfortunately, I'm sure we could keep discussing all afternoon, but that's all we have time for. So I'd like to invite each of you to give just a brief closing remark and takeaway for the session today, and then we will conclude. So Sandy, let's start with you and then over to Kathryn.
Well, first of all, just my thanks and gratitude to Completed Life, to all of you for this opportunity to participate and provide a clinician's perspective and a Canadian perspective on assisted dying. I think there's a lot to be learned as both countries and others as well go through this whole process. You know, clearly the world is moving towards assisted dying and in fits and starts in various ways. It's always helpful to hear these comparisons because I think we can learn and reflect on how our own approaches to assisted dying have evolved with time. And we're all an experiment in real life, really, with these processes. I find, and you see things come up. For example, when our assisted dying laws first came up, psilocybin as a way to deal with existential distress, even 6-7 years ago, was not what it is today. So things change, and I think we have to be capable of evolving with the time and taking our time to study these issues so thoroughly. So again, thank you for the opportunity to present and for a very interesting discussion.
Yeah, same. It's been a pleasure. Always great to be with Professor Pope. I do invite everyone who's interested in the psilocybin work to take a look at the website, righttoTryPsilocybin.com, just all spelled out. If you are a philanthropist or you are a donor of even small capacity, support the work if you believe in it, because this is public interest work and it's supported by philanthropy. And we need everyone to lean in with us to take this across the finish line and open therapeutic access to psychedelic assisted therapy in the States. And so love to have you lean in, send your letters to your federal electeds, and let's see this Right to Try Clarification Act adopted post haste and relief of existential distress for dying patients. Thanks so much.
It was just a pleasure to be able to chat with people with such deep decades and decades, probably more than a half century of experience with end-of-life advocacy and palliative care. So thanks very much.
Thank you.
And I want to express my deep gratitude to all three of you on behalf of the Completed Life Initiative. This has truly been a fascinating deep dive into these issues, and thank you for your time. I really appreciate it. And thank you to everyone in the audience for tuning in and submitting your questions. This concludes day one of the third annual Completed Life Fall Conference. Please stay tuned for tomorrow's session, the first of which is the role of autonomy and conscience in a good death, which starts tomorrow, Wednesday at 11 a.m. Eastern Standard Time. So if you haven't already, please check out other resources available on the Completed Life website, completedlife.org. There are many archived videos for your viewing pleasure. So please stay connected with us, and we'll see you next time. Thank you so much.